Today we are going to talk about multi-slice CT coronary angiography, its basics, its past, its present, and its future. I am Dr. Sameh elKaffas from the Cardiology Department of Cairo University. To understand multi-slice CT coronary angio, we have to understand the evolution of the machine, the technique how we prepare the patient, how we perform the scan, how we reconstruct the images, how we display and interpret the images, the limitations of CT coronary angio, and its different applications and future prospects. As time goes by, we have seen major advances in the machine itself, advances in the software required for display and interpretation of the images, decrease in the limitations, and improvement in the applications and prospects of CT coronary. And to understand the machine, we have to understand its evolution. It started with the first generation of a pencil beam X-ray source that is detected by a single detector. This improved to become a narrowband beam sent from the X source using multiple detectors. Then the third generation was having an arc of detectors, and this allowed the rotation of the source of the X-ray and the detector arc around the patient. The fourth generation was having a complete circle of detectors around the patient, and thus the X-ray source only rotates. The fifth generation was the electron beam CT, which is a totally different machine, and it uses an electron beam that becomes deflected by a strong magnetic field and passes through the patient who is stationary during the acquisition. The sixth generation is an important one. It is the spiral CT, which uses the slip ring technology, which allows continuous rotation of the tube and the detectors around the patient, while the patient himself and his table is moving through the gantry, which is composed of the tube and the detectors, and this creates a spiral acquisition. The multi-slice spiral CT is basically increasing the number of the detector rows that detect the X-ray emitted from the X-ray source from one to multiple detector rows, and this increased the anatomic coverage that is taken during each emission of X-ray from the X-ray source. Its advantages is mainly having longer anatomic coverage, so this is achieved by increasing the number of slices and thus increasing the number of images acquired per gantry rotation. However, this was accompanied also by improvement in the temporal resolution, which can be achieved by increasing the speed of the gantry rotation around the patient, and thus we have less time for acquisition of each image, and improving in the spatial resolution by using thinner detectors so we can generate images of higher quality and better resolution. There is advances by increasing the number of slices. For example, we have now 320 or more slices that can be used during each image acquisition, and this improves the coverage per rotation and decreases the acquisition time, and we can even take a picture of the heart in just one beat. On the other hand, what is really important is improving the temporal resolution, and this can be achieved by increasing the gantry rotation speed or using dual sources of X-ray with dual detector rows, and this can improve the temporal resolution and allow us to take scans at higher heart rates during acquisition. To prepare the patient, we have to exclude patients who are not suitable for this type of radiation exposure and contrast material administration, as patient with contrast media allergy, patient with renal impairment, pregnant women, and the presence of arrhythmia is actually very unique to this technique because the technique depends on having a steady regular heart rate. As we can see later, we can take the images uh, from different heartbeats, not just single heartbeat. The heart rate, the lower the better. It's ideal now with the new generation machines to have a heart rate of 70 to 80. This is a major improvement compared to the previous generations, which required low heart rates of around 60 beats per minute. The patient has to be fasting for 4 to 6 hours, and he or she has to be able to hold the breath for 4 to 5 seconds. And again, this is a major improvement regarding the older generation, which required longer breath holds of up to 40 seconds. This technique is ECG gated, and continuous ECG monitoring is mandatory. The contrast material used is non-ionic iodinated contrast material with a concentration of 300 to 370 milligrams per milliliter. The volume needed is on the average of 60 to 70 milliliters per patient, and it is injected by an automatic injector with a rate of 4 to 5 milliliters per second. It is better to have dual head injectors because after injecting the contrast material, we inject what we call a chaser bolus of saline that is injected in a peripheral vein in the right antecubital vein. The aim of this chaser bolus of saline is to push the contrast material column as rapidly as possible and undiluted as possible to reach the left side of the heart and opacify the coronary circulation. As for the scan technique, we start from the level of the left main coronary artery to below the diaphragmatic surface of the heart, which is usually a length of 12 centimeters. This is determined by scout views, which look like a traditional chest X-ray. Circulation time is the time needed for the contrast material to reach the left side of the heart from the site of injection. This can be determined by two techniques. Either we calculate the delay time by injecting a test bolus of contrast material 10 to 20 milliliters and take repeated scans at the level of the left main coronary artery to determine the time needed for the contrast material to reach the coronary circulation. Or we can use what we call the time density curve. We take different or successive scans at the level of the coronary arteries. We put a region of interest at the aorta, and when the level of the contrast and attenuation reaches a certain threshold, the machine automatically starts the scan. Image reconstruction starts at the level of the machine itself, where it performs what we call the Z interpolation, in which axial images are generated from the spiral acquisition. Slice overlap, we take different slices at different phases of the cardiac cycle, as we see here. We have two techniques of gating. Retrospective gating, as we can see in the lower part of the image, is basically we give the machine orders to emit X-ray and produce radiation exposure during the whole of the cardiac cycle. We can later retrospectively choose the phases of the cardiac cycle with the least cardiac motion to evaluate the coronary arteries. This gives us room to make adjustments if there is cardiac motion artifacts to detect the different segments of coronary arteries in different phases of the cardiac cycle, however, comes at the expense of increased radiation exposure to the patient. The other technique, what we call prospective gating, as we can see in the middle part of the image, is simply we do the scan, the X-ray exposure and the acquisition in selected phase of the cardiac cycle, and this usually occurs in the mid-diastole. This definitely provides gains in reducing the radiation exposure to the patient. However, it comes at the expense if there is some instability in the heart rate or occurrence of arrhythmia. This can produce cardiac motion artifacts that can sometimes make the whole acquisition uninterpretable. It is important to know, as we can see from this image, that the volume of data generated and the volume of data that we use to visualize the cardiac structure, including the coronary arteries, usually does not come from a single heartbeat. These are different data sets. Each data set comes from a different heartbeat, and they are combined together to produce the final imaging volume. To overcome the motion artifacts, because the heart and the coronary arteries are continuously moving, we can use retrospective gating to detect the phase of the cardiac cycle in which the least cardiac motion occurs. With advancement in the CT machines and improved temporal resolution, it is usually now we can usually now detect and evaluate all arteries in a single phase of the cardiac The image display starts by taking the volume of the data to an offline advanced computer workstation. We usually start by reviewing the source, the axial tomograms. Orthogonal images, the sagittal and coronal, are usually also used to evaluate the different cardiac structures and the coronary arteries. We can use oblique images to get cross sections of the different segments of the coronary arteries, and we can use secondary 3D reconstructions like the maximum intensity projections, curved multiplanar reformations, and volume rendering techniques. As for the axial images, we have to know the axial anatomy of the heart and the coronary arteries, starting from the level of the great vessels, as we can see in the upper left image, down to the diaphragmatic surface of the heart. And as we go through the axial anatomy of the heart and its coronary arteries, we can see different segments of the cardiac chambers and the coronary arteries. The axial images are called the source images because these are the images that come out of the machine and from which we do all the reconstructions. It is important to start by checking for artifacts, whether cardiac motion or respiratory motion artifacts, the presence of dense calcification. We can also use them to estimate the chamber sizes, presence of myocardial thickening, or any congenital defects. 3D reconstructions cause loss of data and not just gain of image quality. The more you reconstruct, the more you lose data. So when you see an anomaly or a lesion in a reconstructed image, you have to go back to the axial or the source images to determine if this is caused by an artifact or it is a true genuine lesion. The maximum intensity projection is basically using a stack of slices to be able to evaluate a longer segment of the coronary vessel. But again, this can be used with oblique images to create summation projections, which shows images that are very similar to conventional coronary angiogram, and it has the best accuracy for detection of coronary stenosis and occlusions. Curved multiplanar reformations, these create arbitrary imaging planes that follow the tortuous course of the different coronary arteries, and we can see a curved non-anatomical image of the whole coronary artery in question, starting from its ostium till its end. Volume rendering techniques are a pseudo three-dimensional display that create outstanding demonstration and teaching tool. However, they have the worst accuracy for detection of coronary stenosis and occlusion, but they have good potential to show the different anatomical relations of different structures, and they are important in congenital coronary anomalies, for example. To interpret the image, it is better to start the learning curve by combining a team of cardiologists and radiologists to gain experience in both fields. There is no systematic universally accepted approach developed. However, we should go systematic segment by segment of the different coronary arteries for the presence of significant stenosis or occlusions, and it is better in the early part of the learning curve to compare with conventional coronary angio to increase the experience. As for the limitations of the technique and causes of non-accessibility of coronary stenosis, the most important is the presence of cardiac motion artifacts, which can result from simple elevation of the heart rate, tachycardia during acquisition, or occurrence of arrhythmias like premature beats during the acquisition itself. Other causes of motion artifacts are the respiratory motion artifacts, which sometimes create uninterpretable images of different segments of the coronary arteries. Small vessels less than 1 millimeter due to the limited spatial resolution of cardiac CT are sometimes uninterpretable. The presence of what we call the blooming or the beam hardening artifacts are caused by high attenuation structures like the presence of extensive calcification, adjacent contrast field structures, and presence of metallic artifacts generated from the metal of the stents or surgical clips, and finally poor opacification of the coronary arteries because of the poor timing of the contrast material. Sometimes different limitations coexist in the single imaging, rendering these images uninterpretable. As for the applications of multi-slice CT coronary angio, definitely the first application is detection of coronary stenosis and occlusion, and its role is established by now. One of the important findings that we can see here that it is not only a immunography like conventional angiography, but it allows also characterization of plaques, the presence of calcification, the presence of high lipid cores, and so on. And we can use different techniques like the three-dimensional techniques to visualize the segments that are occluded in the arteries. As we can see here, we can also use curved multiplanar reconstruction. For example, this we have an occluded segment in the left anterior descending artery. We can evaluate the occluded segment properly as regards its length, the presence of tortuosity or calcification. We can also see a significant lesion in the proximal part of the left circumflex, and we can see from evaluation of the right coronary artery that there is no significant stenosis in this artery. This has been confirmed with the conventional coronary angiogram of this patient. Evaluation of patient post-coronary artery bypass grafting surgery. Multi-slice CT coronary angio has a high accuracy for detection of occlusion or lesions in the coronary artery bypass grafts. However, the presence of artifacts from metallic clips can cause deterioration of the image, and however, we can use different techniques for easy detection of occluded grafts, especially in the absence of surgical reports. One of the limitations of the technique in this particular set of patients is the presence of advanced atherosclerosis with dense calcifications in the native coronary arteries, which renders their evaluation sometimes very difficult. As for coronary artery stents, CT coronary angio is not the best technique to evaluate the stents because of the artifacts created by the metal from the stents, and this can cause overestimation of the presence of in-stent restenosis. However, several studies have shown that we can usually use CT coronary angio to determine the patency and the presence of in-stent restenosis in stents larger than 3 millimeters in diameter. Congenital coronary artery anomalies are one of the areas where CT coronary angio excels. It is an excellent tool for visualization of the congenital anomalous origin of the coronaries. As we can see here in the lower images, there is an anomalous origin of the left main coronary artery from the right coronary sinus, and it passes the malignant interarterial course between the RVOT and the aorta to reach the anterior interventricular groove. We have to look for other findings, whether they are cardiac findings, for example, masses like myxomas or tumors. The presence of thrombi, as we can see in the upper right hand image, we have a hypodense thrombus filling the left ventricular apex, and even evaluation of the cardiac valves, as we can see in the lower right hand image. We can see thickening and doming of the mitral valve leaflets, and we can see thickening and calcification of the aortic valve leaflets. Other findings at the level of the great vessels, you can very easily detect the presence of aortic aneurysms or dissection. We can check for the presence of pulmonary embolism, and these can be the causes of the chest pain, or what we call the base for the triple rule out technique. We can also detect extracardiac findings like the presence of pulmonary nodules, consolidation, or pleural effusion. Even the upper abdominal cuts, we can detect hepatic lesions. The presence of hiatus hernia is actually clinically significant because this can be the cause of the patient's symptoms. And in the era of the COVID-19 pandemic, we can detect the ground glass opacities, which are one of the hallmarks of this infection. In 2006, different governing bodies like the American College of Cardiology, American College of Radiology, Society of Cardiovascular CT, and Cardiovascular MR have issued appropriateness criteria when to use cardiac computed tomography. This criteria included 13 indications in which cardiac CT was appropriate to be the imaging technique of, and there are other indications that were uncertain this time, and some indications were inappropriate to use cardiac CT for. This was updated in 2010 by the same organizations, and they covered different indications for the coronary or the cardiac CT, ranging from detection of coronary artery disease and using coronary CT angio in different clinical scenarios, even in sometimes with the onset of new onset heart failure or detection of arrhythmias with unknown cause, and the presence of prior testing techniques, evaluation of patients for preoperative evaluation of patients for non-cardiac surgery, risk assessment post-revascularization, whether following PCR or CABG, and in congenital heart disease and evaluation of intra and extracardiac structures. So the list of appropriate indications have increased from 2 pages now with 35 appropriate indications. There is also inappropriate indications, as we can see here, and they created different algorithms for different clinical scenarios in which we can determine which clinical scenario it is appropriate to use the coronary CT angiogram. Different clinical scenarios exist in terms of acute symptoms, post-revascularization algorithm, in the presence of prior test results, presence of non-acute symptoms, evaluation of asymptomatic patients, detection of coronary artery disease in other scenarios like the presence of newly diagnosed clinical heart failure, preoperative coronary assessment for non-coronary cardiac surgery, and detection of arrhythmias and the cause behind it. Evaluation of cardiac structure and function are gaining a lot of here. And the European Society of Cardiology also issued this paper regarding the indications, applications, limitations, and training requirements for cardiac computed tomography. To summarize their recommendations, in detection of coronary artery stenosis, it is recommended in patients with intermediate risk of coronary artery disease. As for stent imaging, its routine application cannot be recommended. For coronary artery bypass grafts, this is very useful in selected patients in whom only graft patency is necessary. However, inability to reliably visualize the native coronary arteries poses severe restrictions to its general use in this category of patients. And finally, for coronary artery anomalies, it is a first choice imaging modality. The future development of CT coronary angio depends on development of the machines itself in 3 major axes. First is the spatial resolution by using better and thinner detectors to increase the resolution of the images. Then improving temporal resolution by using higher gantry rotation speeds and other techniques like dual sources that will provide us the ability to image patients with high heart rate. And finally, increasing the anatomic coverage by increasing the number of slices, which can allow us to have less scan times and less breath hold times. New applications are in the horizon, for example, computation of fractional flow reserve from the CT coronary angio images. These are using computational models based on cardiac CT angiography. These physiologic models are computed by supercomputers because they involve very advanced and complicated equations. and we can use these to calculate the FFR from CT images and creating CT maps in which we can detect which stenosis are actually causing myocardial ischemia. This is an example of one patient having intermediate stenosis in the right coronary artery, and the invasive FFR correlates well with the FFR generated from the CT images. I hope this was a beneficial presentation about basic multi-slice CT coronary angio, and thank you for your attention and time.